targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community.
Morning, everybody. A warm welcome to you all. Today, we have the pleasure and the honor of being dazzled by a very intelligent, wonderful GP who is a mother of 3 strapping lads, who has this passion about Black involvement in clinical research. As I said, she's a GP and she's a clinical lecturer at the University of Newcastle. And of course, above all, she works for the NIHR. I'm not sure whether people know about that, but it's the National Institute of Health Research. As I say, she's passionate about clinical research and has many academic publications focusing on clinical research. I would probably introduce myself just in case nobody knows me, but I would have thought I don't need introducing. My name is Mr. Mohammed Kamara. I'm an A&E consultant myself, and I've been with CAN for as long as I remember, I think about 5-6 years, and I'm one of the directors as well. So the lady I'm talking about, who is a colleague, who is a GP, who is a mother, and a research tutor, both for undergraduate and postgraduate, is Dr. Doyin Alao. So I'll probably, without further ado, because we're running a bit late now, it's like 6 minutes, I'll hand you over to her and she'll take us away with this very, very important topic today. Thank you so much. So over to you, Dr. Alao.
Hello, everybody. Thank you, Dr. Kamara, for the kind introduction. That was a very kind introduction. I'm Doyin Alao. I'm a GP and an NIHR clinical lecturer in Newcastle University. I am passionate about research. I'm passionate about teaching, and that's why I'm really pleased to be with you this morning, talking you through the importance of Black representation in clinical research and also how we can safely participate. So thank you very much. Would somebody share my screen or allow me to share? Thank you. I think I'm not allowed to share. No. Yes, I'm allowed to share. Okay. So thank you very much this morning. I'm going to start with what is clinical education research? What is clinical research? There we go. Am I sharing nicely? Is it showing for you? Yeah.
No, come on, yes. Yes.
Okay, brilliant. So clinical research is medical research on human subjects. So basically, research on human participants to understand clinical conditions. How do they present? How do they look like when somebody has a condition? Or research that is aimed at finding out or testing the effectiveness of methods for treating different illnesses, or even to find out the cause of the illnesses, like what can cause different types of illnesses. Or sometimes we can do research to find out how we can improve investigations like x-rays and CT scans and all that, and how we can improve the treatments that we already have, because science is changing every day and our knowledge is changing and expanding every day. So we want to move with the times in clinical practice to be able to offer the best available diagnosis and treatment for patients. Now, why am I here today? I'm here today because I'm passionate about Black representation in clinical research. Black patients have higher rates of certain diseases like cancer, heart diseases, diabetes, asthma, pneumonia, but also we have worse outcome in certain conditions. So like maternal death, for instance, Black women are 5 times more likely to die from birth-related pregnancy, birth, and delivery-related illnesses than the general population, and that's a big number. Now, the other example is during COVID. Sadly, the COVID pandemic, it caught us unawares. We didn't know about it, but it was actually a test of the health system. During COVID, people died, sadly. Some people had illnesses and they continued to have symptoms even, months and years after. But what was really sad for us in the Black community is that Black patients had higher mortality with COVID. So more people were dying, more Black patients were dying with COVID, and we didn't know why. Now, what was sad is during COVID, researchers were doing, we had to do it, research very quickly to produce more, evidence about what works and what doesn't work for COVID. And because Black patients were dying more, they needed more Black participants to, come up to, to participate in the research. But Black patients weren't. So we didn't know what works for the Black community and what doesn't work. And that was sad. We felt quite helpless about it. Now, with stroke as well, Black patients are more likely to die from stroke as well. And of course, when I've said all these things, and as well as other inequities that occur in the system, it wouldn't be surprising to hear that Black community, Black individuals have shorter life expectancy. So it's important for us to know what works for our community, and that's why our representation matters. So when we have more Black representation in clinical research, it helps us to find out how diseases affect Black patients, what kinds of treatments are effective for Black individuals, and what are the culturally sensitive treatment approaches. Now, I'll give you an example. We've said Black individuals are more likely to have diabetes. And when we have diabetes, the first line of management is diet. So we say to patients newly diagnosed with diabetes, reduce, fat in your diet, make these changes, eat more fruits and vegetables. And to empower these patients to be able to look after their health, we give them examples of meal plans for diabetes. But I've got people with diabetes in my family. And when I went online to look at meal plans for people with living with diabetes, many of them were things we don't eat in our community. So at the end of the day, it's not, although these things are out there and this information is there to empower people, these things are not actually culturally sensitive. We are not going to, we're not going to follow those advice because it's just things that we don't eat. And that is part of what affects the mortality and the outcomes with Black patients, because all these things are there and they're pretty fine and good. But if we're not going to interact with them and if we're not going to use them, then we need some other guidelines and advice that are going to be sensitive and going to be useful for us. And then the most important thing is we've said that these inequalities, they're complex and they're not only about genetics or about what we eat and what we do, the choices that we make. Some of it are also about the policies the guidelines, these things that will affect people on a larger scale. Now, if Blacks are more involved with research, then their views are going to inform the policies, and the long-term effect of that is to reduce the inequalities and the inequities that we see in healthcare. I'll give you some real-world examples here. And before I give you the real-world example, I love pizza. And when I'm making pizza for my family, I normally ask everybody, what do you like? What ingredient do you like to put as a topping on the pizza? And everybody comes with, I like sweet corn, I like peppers, I like, chicken. And then, I put everything on the pizza. And then at the end of the day, everybody in the family, when they take a bite of the pizza, they will find something that they like there so they can eat it and enjoy it. And that's what representation means in clinical research. Now imagine if one of my children does not come to tell me what they like in pizza. So I'm taking the ingredients and everybody's have what they like there, but one person doesn't come, and I just make the pizza anyways. And then they take a bite of the pizza and they don't like it because it doesn't have anything they like. And they were not even involved in the planning or the making of the pizza. So that pizza is useless to that child. And that's what happens with research if Blacks are not represented. The output of the research, what we do at the end of the day, the treatments, the diagnosis, the guidelines that we produce from that research would not be useful for the Black communities. And that is part of what causes the inequitable outcomes that we've discussed earlier. These are real world examples. So the first example here is Black patients are more likely, Black individuals are more likely to have prostate cancer, and sadly, more likely to have the more advanced forms of prostate cancer. Now, there was some research done about the effectiveness of treatment for prostate cancer, and in that research, we had a good representation of Black men in that research. And because we had good representation, they could find out that actually radiotherapy works better for Black individuals. So we could then offer radiotherapy to them, and then that improves the outcome for Black men with prostate cancer. Now, if these men didn't come out to get involved in the research, we wouldn't know that. So we'll be giving the standard treatment options to them. And then we wouldn't know why they're not doing very well with the treatment. The middle example here is about the oxygen probe. So we use the oxygen probe to monitor how much oxygen is in the system. And it lets us know how unwell patients are, whether they need more oxygen or whether they even need to be in ITU, or whether they will be okay breathing by themselves. Now, during COVID, we found out that Black individuals, when you use the oxygen probe for them, it overestimates their oxygen levels. So we can't really tell how much oxygen they're having. Now, up until the time this was found out, it means that there are so many patients sitting down there with low oxygen levels who would have needed extra oxygen and didn't get it. And then, of course, they will get more poorly. And some of them will die because of that. But finding out that the oxygen probe is not really telling as much as we want for the oxygen levels, then we use other ways to find that out. Now, the third example there is cancer genetic screening. Now, there were some tests done about testing, not genetics. So women that have been diagnosed with breast cancer, they do some genetic tests to see whether some medicines is going to work well on them or not. Now, the representation of Black communities in this test was little. So we couldn't really tell whether the chemotherapy, the medicines, is going to work well for that community. And this is what happens with health generally, where we have poor representation of Black individuals in clinical research. So what are the barriers for this? One of the big things here is about trust. Now, we cannot pretend that we cannot pretend that we all feel that we're treated equally by the system. We cannot pretend that. So some of us might have heard about the syphilis study that happened in USA many years back about men having, they were doing some research about how syphilis presents in people. And they studied these Black men. I didn't tell them that they were not giving them the right treatment for syphilis and allowed them to progress with the disease, observed how syphilis affects people, sadly up till death as well. And this caused a lot of distrust among the Black community, particularly in US, about taking part in research. And we still have a lot of distrust as well in many countries as well about, Black communities taking part in research. But this situation led to guidelines and protocols about ethical research practice. And because of all these kind of situations, we now have rules about how to involve patients in research to make sure that we're minimizing the risk, but also we're telling them exactly what is happening, what the likely risks are, how they can get support, and whether they really want to take part or not. Then there's awareness. Some of the issues here is some Black individuals do not know how to take part in research. Even if they want to take part, they don't know how to take part. They don't really, even though researchers are trying to, reach a wide range of people, those researchers themselves don't know how to reach the Black communities. So their campaign to get more people involved in research does not reach the Black community as well as it reaches other communities. And then the Black individuals don't know how to do it. And we'll talk about how to address that. And then there's the spiritual beliefs as well. So sometimes there might be beliefs around, illnesses and diseases and cure comes from God, which it does, but also there might be beliefs about, well, research is harmful and it has no place in how illnesses and diseases work. One of the things we said about the awareness is that there are fewer Black researchers, which means that there's, again, we talked about trust. So if you see somebody like yourself inviting you to take part in something, then you're more likely to take part in that, isn't it? So with having fewer Black researchers, it makes it harder to recruit Black individuals into health. But also, Black people like me will understand how to communicate and how to reach out to the Black communities. But with less Black researchers, then it's harder. And then lack of outreach or access. So we talked about that in awareness, isn't it? So some Black individuals just don't know how to do that. But also, even if they know how to do that, there might be some other barriers to them taking part in research. So it might be about language barrier. It might be about transportation. It might be about who is going to look after the children whilst I attend these visits, or who is even going to look after my parents that I'm caring for, or even, financial reasons as well. Going and coming is going to cost things. So all these things as well affect Black involvement in research. So if you're going to get involved in research, I thought if I give you some ideas about, what might happen with your involvement in research, it might help to, kind of reassure you as well, and know what to maybe encourage you as well to take part in research. So when we ask people to take part in research, sometimes we might be asking them to just share their views about what it means to live with certain conditions, or their views about maybe eat, diet, or exercise or things, or even their views about the experiences with the GP or with the surgeries to improve those experiences. It might be about reporting your symptoms only. So they might follow you up. So if you have a condition, for instance, and they want to know how that condition, how it progresses with time, it might just be about reporting what you have. Did you have breathlessness? Did you have this? Or every time you have breathlessness, you let us know. So then we write it down. So they might not do anything different to you. It might just be having the standard treatment, but you're just, coming from time to time to say how, that illness might be affecting you. The same thing about reporting exposure. So they might say, okay, this number of people have COVID and they had long-term COVID. We want to know what has happened to you. What are the risk factors for long-term COVID? So they might be asking you things about, have you ever smoked? Do you do exercise? How much exercise do you do? And those kind of things. What kind of diet do you have? Just to know what are the risk factors, what makes people have that long-term COVID or not. Research might be more, I won't say invasive, but not in that term, but it might be more about telling and reporting. It might actually involve taking measurements. So they might ask you to come to the hospital or the general practice surgery maybe every 2 months to take measurements about your blood pressure. It might be your weight and height. It might even be asking you to give some samples, maybe blood sample or urine sample, to check whether you have certain things and monitor certain things in the body. But they will tell you this when you are enrolling in the research, and they will tell you how long as well. So I've moved to providing samples as well. And then the last thing, which is we call them clinical trials, is to test medications. So they might want to test the effectiveness of medications. Now, I'd like to reassure you that before they start testing on human beings, they would have tested these things in the lab. They would also have tested this medication on a small sample of healthy individuals to see the safety of these medications and to see if there's any side effect. And then they test on larger samples of individuals with the condition that they are trying to monitor. And then, of course, they then test it again with a bigger sample and use it normally in normal life and see how that works in normal life. So there are many safety procedures before they start to give you a medicine to test. Now, if they ask you to test a medicine, usually what they do is they take a group of people and they kind of divide those people into 2 arms. One arm is the test, the new medicine, and then the other arm is either a placebo, so it doesn't have that medicine in it, if that is appropriate, if it is appropriate to not treat. Okay. Or the other arm will be what we normally do with that patient, with those groups of patients. So let me give you an example. COVID. Now the standard treatment for COVID with people with low risk is to just watch and wait. We don't do anything, isn't it? Now we can take a group of 1,000 people, divide into 2 arms, 500 people, new medication. We've already done a lot of safety trials before this. We give them that new medication. And then the other 500 people, we give placebo, nothing in it, but it looks like the medication. And then just observe them over 2 years to see whether they, got better with the COVID, which of the 2 arms had long-term COVID or not. And then it helps us to know whether that new medication is actually doing us good or not good at all, or actually maybe more harm than good. And then we withdraw it from the market. So if you want to take part in research, what are your rights? The first thing is adequate information. Like I told you, because of the historical things that have happened with ethics in research, there have been guidelines. So when researchers like us want to recruit patients into research, we have to go through ethics. And that ethical procedure is to submit it to a group of people that will check what we're going to do to protect the patients or individuals that are taking part in the research. Okay, and for you, it's important to actually find out if that research has undergone ethical approval, because if it has, it's a kind of safety check to say, okay, many things have been done here to make sure that they're doing it right and they're not causing me any harm. So you want to check that, have they undergone ethical approval? Which ethical committee had reviewed this research process, and what was the outcome? What did they say? Were they happy? Were there some concerns? You want to check that. So when a researcher comes to meet you and say, oh, they want to do some research, they should tell you what the research will entail, what the likely benefit of the research is. Why are they doing it? Because we don't just do research for no reason. And what the likely risks are to you, and how they will monitor that risk and reduce that risk or support you if that risk, that harm, or happens to you, how they intend to support you. So, and that information is usually given in two forms, verbally and written. And if you have questions, somebody want to say? Is it 5 minutes more for me? I thought somebody wanted to say something. If you have any questions, feel free to ask. There will be a contact detail to ask questions. Feel free to ask those questions because it's your own time, your own life, your own resources you're giving to them. So they would be happy to answer the questions. Second thing is consent. I've put consent next because consent depends on adequate information. If you have enough information, you'll be able to weigh the risks and the benefits to you and decide whether you want to participate or not. You can always decline. It is not compulsory to participate in research. And you might change your mind later as well. You might have said yes, but later on thought about it and say, okay, actually, I don't want to go again. And there should be a process for you to, decline, maybe a number, or to tell the person when the person that's contacted you to say, no, I don't want to do this again. Now, the next thing is privacy. Again, we have rules about privacy, privacy of information. And many times your details will be kept anonymous. That means nobody will know that it is Doyin that said this about this. And nobody will know that it is Doyin that was going to the toilet 10 times a day when she had COVID. So although they will say people that have COVID are more likely to do X, Y, and Z, but they wouldn't know that Doyin did this or Bolanle did this, they wouldn't know that. So you have a right to your privacy. And again, we have procedures to ensure that we keep your information safe. I've put reimbursement or support to participate. Most of the time, participating in clinical research is free. It's done willingly, and they don't give, you're not paid for it, kind of. You're not giving money for it. But we've realized that sometimes there might be some barriers to participation, like traveling, like caring for, for loved ones or for children or for parents, or even sometimes you take out of your personal time. You have to leave work to go and participate in research sometimes, isn't it? So some research will have provisions for that. So if you have any particular barrier to taking part in research, discuss that with the people recruiting you, and they might have some things in place for that. And I forgot to put there as well, translation service. So if you have any assessment requirements, so maybe accessibility, like, wheelchair or language or hearing, those kind of things, it's worthwhile discussing with the team. They might have some support for your involvement, because we actually need a diverse involvement in research so that whatever we say is the treatment or is the good diagnosis or is the good way to approach this will work for a wide range of people. Now, I put results there. Many times we take part in research. We want to know what happened at the end, isn't it? So you have a right to know what the results were. What have we learned from it? And how is it going to change our practice? And you can always ask again, the same people that introduced you and to the research, or invited you to the research. You can always ask them, please, can you let me know when the results are out? Sometimes it can take so many years, and they might give you a website or a web link that you will find the results of the research here when the results are ready. So how can you participate then? If you're interested in participating, and I hope I've encouraged you here to participate, you can speak to your healthcare provider. That could be at your general practice surgery or the hospital if you are receiving treatment in the hospital. Some of these healthcare services are research active. So you will see some posters on there saying, we're research active. We conduct research here, and here's the number or the website if you want to sign up to research. Okay, so, or if it's not there, you can always ask. Sometimes that's on their website as well. But actually, you don't have to do that. You can actually check the website of the local university, because they'll be having so many research going on. And if you don't find it there, you can send a message to, you can email the contact there. Now, I've put this link here It's NHS UK and it's about clinical trials. It tells you a lot of information about clinical trials, how it works, what the risks and benefits are, what your rights are. But very importantly here, it tells you different groups that recruit individuals to take part in clinical trials. So you can set up those groups and then check in your area to see, if they want something that you can take part in. And then finally, you can sign up to various registers of people that want to take part or newsletters. Because I'm part of NIHR, so I can tell you about NIHR, but there are other charities, there are other groups and charities that actually have a register or a newsletter to let people know about research. So for NIHR, it's the NIHR Be Part of Research. There's a website that tells you again about, taking part in research and what's your rights and everything. But actually on that website, you can put in your postcode and it tells you the various research that takes part in your area and how they are recruiting and who they would like to take part. So you can then, contact them and take part in that research. So it's very good if you want to take part in research. And sometimes you might just look at that website to see what research is happening. And maybe you might be interested in, just knowing what's happening in the area. Or you might have a medical condition or your loved one might have a medical condition. So for instance, dementia. And you want to see what research is happening about dementia. So you can put in dementia there. And it tells you the various trials that are happening about dementia. And you can then contact the people saying, I want to take part in this, in this. And then they can let you know, how to take part in it. So it's really, really good for people that want to participate in research. And it's also good for people that are just curious to know what's happening around them. I'm going to share you an example of a real life story of a Black individual that got involved in research. So Nicholas, he works, and this is on NIHR Be Part of Research. There are more stories there. He works with the ambulance service, and he participated in the post-hospital COVID-19 study. They wanted to know, what happens to people that have been hospitalized. And this tells you his experience, examples of what happened. So he tells us that he had 4 visits in a year, and he had some blood tests, he had breathing exercises, and he also completed surveys online, asking about, his lifestyles and other things. But what he also had to do was to speak to researchers about, his experiences. And sometimes I told, even though the participation is about, there's no direct benefit to you, sometimes you see some benefits from the research. So for instance, he was referred to the counselor because they found out that he's having flashbacks, which can affect his mental health. So those are some of the goodies of taking part in research. And then some other goodies are, you get, because you're going to visiting the hospital a lot of times, you get, more checkups, and then they can find out if something is wrong and treat you quickly as well. And then you can know more about your body as well. You know about your blood pressure, you know about your cholesterol, you know about this, if those are things that they're checking. But also, some people just like speaking to people, and it makes them happy to speak with people. So Nicholas says we need to keep going with research, and I'll end with that. Thank you.
Thank you so much, Doc. That was wonderful, succinct, and I myself have, learned a lot. I am not directly involved myself with research, but I've always been, as I say, someone passionate about that. So just to add to what Doc has said, for me, in my view, why is it that, us as Black or ethnic minority communities need to be involved with research? There's a few things. Research, and so it actually ensures that treatment is effective, i.e., a person's race and ethnicity, along with other factors, can affect how they respond to a treatment or a drug. And so therefore, a clinical trial will help to actually establish that, adequate representation in trials is critical for understanding those differences that I've just mentioned. The disproportionately high incidence of disease, as Doc mentioned, amongst us is also a very good reason for us to actually find out why it is such people or some people like that and other people are not. And I think that is important, because what you don't partake in, you wouldn't actually have any nuance of actually how it works on you. It actually also drives new discoveries, from what I know. And so therefore, if you have diverse participants in studies, this can lead to groundbreaking discoveries that might otherwise be missed. So it's important that, and of course, above all, it improves, as Doc has said already, health equity. For decades, I mean, she mentioned Tuskegee, in where the syphilis, I would say, unethical, treatment or research took place. But for decades, health research has been conducted mainly on populations of European descent, and leaving knowledge, gaps concerning other groups. Now, increasing the representation of our people in clinical research, in my view, is crucial, and it's a step that is required towards achieving health equity by ensuring that all communities benefit from scientific advances. I think she will definitely agree with that. So, you talked about COVID, Doc. Now, again, that Tuskegee experiment, albeit unethical, came into view. It loomed really large, because I was involved in the trial, that trial to get the uptake amongst our people to be really high of the vaccines. You may have seen bulletins, you may have seen recordings and things about me in that regard. But what I found was people didn't trust the individuals doing that. And so my question is, how do we increase this trust? Because everybody cites, look at what they did to us in Tuskegee. People died, some of them 3 decades, looking at, syphilis, first degree, second degree, third degree, and then fourth degree. And as you said, up to death, which to me is the most heinous crime you can commit on human beings. And if it wasn't for the fact that there was a journalist that blew this out of the water, we wouldn't have known about this. So what I'm trying to say is, how do we increase that level of trust amongst our people? Because that's what they're saying. If you have cancer for how many hundreds of years and nobody has found a vaccine, and yet within 12 months you found a vaccine for COVID, what is that saying about us? So I don't know what ideas you may have that would probably try and dispel this myth and push us forward.
Thank you. So that's very important. And like we said, trust is very big, like you said. I can't spend the whole day talking about it. Now, to promote trust in the Black community about research, it's about information. Information is key. And when I say information, I don't mean just the good things. It means everything. So if you want, if you want us to take part in research, you have to tell us what the research is about. You have to tell us what taking part in research entails, what the good things are and what the bad things are, being transparent. And also, you have to connect, because trust is usually based on a good relationship. So that relationship has to be there. And what do we mean by connecting? It means speaking our language. When you come to us to invite us to take part, know what matters to us and talk about those things that matter to us. So, for instance, let's talk about the COVID now. If you come to me asking me to take part in COVID, if you tell me that I know that Black individuals, are more likely to die with COVID, and that is a problem for me, already you've got a bit of my attention there, isn't it? And trust, because it's like, okay, that matters to you. Okay. And then if you talk about, let's say dementia, for instance, about those cultural values about dementia, if you are aware of those cultural values of the Black individuals or the Black communities, and respect those cultural values in your relationship with them. And so that's why we said information that is put out to the Black communities have to be culturally sensitive. It has to speak to us. If it speaks to us, then we're more likely to trust. Now, the other thing about trust is I'm more likely to listen and value what people say if they share things in common with me. So we want more Black individuals to be involved in research. So that's researchers themselves, but also, even apart from the researchers, there's something we call public and patient involvement in research, and also in health. So if we increase the Black participation in public and patient involvement, then they will be able to serve as an intermediary between the Black communities and the researchers themselves. So I'm encouraging you as well, whenever there's an invite for taking part in PPI in research or in health, take part so that people can know more about our values and connect more with us. Thank you.
Thank you for that, Doc. Now, there's a question from YouTube. They're saying some issues can be related to finding the veins on darker people with darker skin, and sometimes the veins are smaller for some people. Now, obviously, this can be off-putting because they end up being like pink cushions, if you like. They're saying maybe people are not well trained in phlebotomy relating to people with darker skin. And so I don't know what your take is on that, because I know for certain that my close relatives had to suffer the same thing. And I find it common amongst the phlebotomists that whenever they have to deal with someone with a darker skin, they find it difficult to find the veins. Yet, people with tattoos all over their bodies don't have that similar problem. So I don't know what your take is on that.
Thank you. So it's about training. This is about training. So although we're talking more about clinical research here, but also we want to have more evidence as to how to train our staff, the healthcare staff, to relate better with the Black communities. So how does the phlebotomist get better with taking samples from Black individuals? They need to be trained to be able to take samples from a wide diversity of people, including Black individuals. So I have the passion about Black involvement of patient involvement in healthcare training as well. Whenever we invite people to come and help, like as simulators or as actors to take part in training medical students, for instance, because that's what I do, it's most likely, white British individuals that come. So that means our doctors, our nurses, our phlebotomists are more in tune with communicating with these groups of people or taking samples from this group of people. So I'll invite you. I know it can be scary because of course it's the pain that is associated with it, but it's a process we need so that we can let them get more used to doing it and be able to do it better. So it should be able to help the next generations of patients if we can have more involvement in healthcare training.
Thank you so much. Yes, and as I say, it's important point you make, definitely, that you need to be involved in order for you to actually be taken on board. Other than that, it makes it difficult. But then there's a question here from, I think, it says the bottom line. Its bottom line is we think Western society sees our bodies and lives as da 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 da. I think, yeah, that's why people are afraid. How can we feel reassured? And then it goes on to say, if I provided a sample for research and then changed my mind, what happens?
Yes, that is tricky. I like that's a really tricky question. So the first part of it, like seeing you as just there, like just an individual, it is a tricky one. And I think it comes to do with the culture and changing people's mindset about valuing diversity. So it's not only just equality, like having everybody there, or diversity, like having a wide range of people. We want inclusiveness. Inclusiveness is actually valuing the specific inputs that person brings, the richness that person brings. So when you have, like I said with the pizza, right, when you have only just a few variety of toppings on the pizza, that's not going to be as rich as you having various toppings on the pizza. That is that richness that we want in our community. And it all starts with us being there when the discussions are being made, us being aware of those discussions. So know what's happening in the news, know what's happening in health or in various settings, and also being able to speak out, speak out on Facebook, speak out on LinkedIn, share the goodness that we, that we bring to the community, share that everywhere. The second one was interesting. If you provide samples to take part in research and then you change your mind. Now, we as researchers, we want to try as much as possible to give you the power to, change your mind anytime we want. As much autonomy as you want, we want to give you the power to do it. But sometimes those samples, so whenever they're inviting in research, there's usually a stage where you can still withdraw. You can always say you're not coming again. That's fine because that's easy. But if you've given your sample already, there's always a stage where it is possible. So if it's possible to, take your sample out, then that's okay. We will do that. But sometimes the sample has already been mixed. We've already, as soon as in some research, once you've given the sample, even the person taking the sample cannot go back there in an hour and say this sample belongs to this person. So it's not possible to then, remove your sample from the, from the pool. So all we can do thereafter is to stop giving samples, and that's it. And they usually explain that, like at this stage, you can't withdraw anymore. You can't withdraw the samples, but you can stop coming. Does that make sense?
Yes, thank you so much, Doc. Yes, that's really good. It's important for people to know that they can withdraw at any time. You might not withdraw the sample that you've actually given, but you could obviously decide not to participate any longer. And it's not binding, as it were. Now, another question from the group is that as human beings, the first instinct is to seek psychological security, seek a sense of confidence and comfort, especially when it comes from someone you relate to. You tend to be a bit more receptive to interventions when obviously they're coming from someone you relate to. So in effect, I think this question relates to probably developing community champions, people of the same ethnicity or, if you like, background or descent. And obviously when they speak to people, and I think I found that very, very reassuring when I actually did that video, that podcast where we talked to our people, and indeed the uptake was, exponentially, noted to rise after those small things. And of course, when we went to the community, people of faith, men of the cloth and all that did participate, and that definitely reassured them, and that increased the uptake in the vaccines during the COVID. Now, I think I agree with that. But then somebody mentioned that they've observed that most of the drugs that or the medications they are subjected to or maybe prescribed, they seem to be highly toxic and obviously synthetic, which in their view causes more disease and mortality amongst our people. To make it worse, white doctors do dismiss, people of color when they have pain and label it, the pain as aggression, if you like. So what are the plans, if there are any, to provide real ingredients in medicine rather than synthetic components?
Okay, so that's a difficult one.
Yes, I do agree. It's not a straightforward answer.
That is it. Because generally, even with pain, we don't have the full answers. Generally, this is with the general population. And when you talk about dismissing pain in Black individuals, I agree with you. Some people find it difficult to understand our non-verbal cues of pain, frustration, and things. And then the easy label is aggression because you don't understand, like all the nonverbal cues. And I went back to communication, isn't like training. So we're working on training our healthcare staff to be more open with, a wide variety of individuals, not the individuals they've been used to, when they were growing up and all that. So this is one of the problems, the challenges we're experiencing, and we're working on that. In terms of the ingredient for pain, and making it, less, it is something in progress. We don't have answers to pain yet. We don't have answers to, what works best for pain at the moment. I don't know if Dr. Kamara wants to.
Yeah, well, we're given by the if you believe in God, the natural painkillers, the endorphins were endowed to us and were given to us, and these do work. and the pain perception differs from one individual to another. What works less for one person works more for another. So I think the research is centered around getting that, is it P450, something like that? I think you'd know about that, which is important in actually determining what dose is appropriate for one individual as opposed to the other person. Because if your metabolism is really, really fast, you might actually need a top up quicker than somebody whose metabolism is the other way around. So how do you get that is probably the task we face. And I don't think there's a silver bullet or a panacea as a response. I think this is just something on average. So you've got the average and below average and above average. And I think where you fall in is where it's important to actually find out, really. So, but painkillers, obviously, they vary from one to the other. And it's important to remember that what works for one might not work for the other. And so it's a question of, not one glove fits all, put it that way. So you have to actually individualize it. You have to use a bespoke approach in order to make sure that this one works for this individual and not for everybody else. So that is my take on that, really. Yeah. There's something said about I think we're getting to something said about the teaching and the curriculum, which I think without a doubt I agree has to be inclusive. Cultural competency in the training curriculum needs to be reflected. When you look at, I think there was only one lad, I remember him, he's now a doctor, who has that thinking where he decided to look at things from a darker skin perspective. If you watch all the medical books or any of those, dermatology and all that, most of them are on the skin of a lighter skin or maybe Caucasian, when in actual fact, we suffer that as well. For example, jaundice is very difficult, even to actually, someone with anemia, someone who is anemic, obviously it's very difficult to actually reflect that on a darker skin. And so the question is, if that is not being included in the curriculum, i.e. looking at the rash from a black man's or darker skin perspective, what are your thoughts in trying to get that introduced in terms of research, in terms of curriculum and all that? Because that's the way we go forward. Although we say people are not coming as they should, but maybe with this kind of thing, knowing that it is taught competently and taught inclusively in the medical schools, I think will go a long way to reassuring our people that yes, indeed, we're being considered, and there is the quest to equity. I don't know what your thoughts are.
Thank you. So we are working on making our curriculum more inclusive. So we've been doing some work like the darker skin, for instance. So in universities now, there are committees, there are equality, diversity, and inclusion committees that review changes in curriculum to ensure that it is inclusive. Now, I have to say this, that if the committee themselves are going to be predominantly white individuals, then it's difficult to get the voice of Black individuals in this committee. So that's why I keep on saying we need representation. We need representations in various places. So even in the university, we have patient and public involvement in education. So we have patient representatives that advise the leaders in the educational setting, saying, these are things to include in the curriculum. These are things to even test our students about to know whether they've passed the exams or not. And we also have patients that are involved in teaching the students themselves. So they speak to the students and they give feedback to the students like, oh, you didn't notice that I was in pain when I was doing this. You talked about pain and not knowing the pain cues. So I am actually inviting you to take part. So as patients, as public individuals, you don't have to have disease conditions to be a member of these committees, okay? In your universities, local universities, take part in these committees for, advising the curriculum or teaching medical students on the day or role playing, because all these things as well determines what the students learn at the end of the day. But we have things, we're learning more, we're improving this at the moment, and it is work in progress.
Thank you so much. Finally, I think somebody wanted to find out whether the consequences of testing groups and control groups, i.e., the control and of course the experimental group, is it true that Blacks are usually in the testing group as opposed to being in both, i.e., the control as well as the experimental arm of the research?
They are in both arms. So since many of those ethical issues had taken place, we're really strict about making sure that practices are ethical. What happens is when you come, a number is assigned to you or something, a code is assigned to you, and it's a computer that generates a random number generation. So even the person taking it doesn't know. The person that is giving you the treatment doesn't know whether you're test or control. So there's no way, we'll be able to play tricks and make sure that you're in treatment or control. So it is safe, and you can read more about this as well and ask questions.
Thank you so much. It seems as if we've exhausted all the questions, but as you can see, I am somewhere sunny with nice breeze, and the only thing I did now is probably the pizza from Newcastle that has got all the ingredients as well. Thank you so much for that.
You're welcome.
I've thoroughly enjoyed that. Yes. So, is this PhD Montfort? Okay. I don't know who this person is, but I'm sure the Khan group would actually deal with that. They wanted to find out where they can reach you. I think via Khan, we should be able to access that. But maybe we'll give you the final word, just a minute, and then we'll hand over to Natasha.
Really pleased to be here today. The main things that I will say is there are inequitable actions and inequitable outcomes that Black communities face in healthcare. And then one way to address that is to be there. You cannot determine what happens if you are not there when those decisions are being made. Be there when decisions are being made. Be there when the research is occurring, and then your voice matters.
Thank you so much. That seat is empty, so we need to occupy it, my people. We need to be heading the queue rather than staying at the back end of it, because this involves us, and we cannot be more serious than this because we have to be there. It's only when you're there that you'll be considered. If you're not there, there's no chance of being considered. That is the take-home message. Thank you so much to everybody. I'll hand you over to Natasha, but I can thank you so much, Doc. I would try and see. I've got a relation in Newcastle, but I'll make it a point to definitely come and taste that pizza. Thank you so much.
You're welcome.
We hand you over to Natasha. Thank you.
Firstly, thank you both, doctors. I think you had a great interaction. It was the first time that you've been presenting together, so it's very interesting to see you both, how well it went. I wanted as well to say personally, I learned so much, even though I work with Khan and we are so on board with research and we know so much of the importance of it. You added a piece that I can just look for research. I can apply, there is various pieces of research. I don't need to be waiting to be contacted. So I can proactively search for research pieces that I can be part of. So thank you. Really, really interesting session, loads of questions. It comes to show as well how informed our community is, because people are making very specific questions, asking very specific questions. So yeah, it's just really, really important. I wanted to share with everyone for the first time. I thought I was having a sharing issue. So just sharing my screen now. Regarding what we have next. So every Saturday we have Health Hour. The topic is to be announced, so do stay tuned in with our social media, with our WhatsApp groups. We'll soon announce the topic for next week, but we'll certainly be here next week with more health awareness literacy information. Khan has a very important gala coming up. So it's our Black History Month gala. We don't miss an opportunity to celebrate our community. We have had an award ceremony towards the beginning of the year towards Black healthcare professionals. This one is more turned to people that are working within our community. VCSC, public sector, youth, students, just people that we want to highlight that are not always celebrated. Tickets are available. I did put a link on the chat. There is also a QR code. available. The event was on the 11th of October, so right in the middle of Black History Month, and we look forward to seeing you there. For us, Black History Month is not just a one-off, is all year round, to be honest, but we do start with an event that we have in 10 days. So it's our Black History Month Media and Comms event. So it's dedicated to people that work in social media, that work journalists, people that work in comms and marketing, like myself, like my colleague Wise that is on the call as well, students that have interest in this area, community leaders. So it's all about how do we get together to make sure that Black History Month is celebrated with all the pomp and circumstance and visibility that it deserves. We have two amazing speakers that are speaking on different topics on history of Black History Month and Pan-Africanism. Also, we have another lady, Melissa Sidogo, coming to speak about how to tell Black stories in a different way with different fresh eyes. She's a very experienced, awarded journalist. So I'm really looking forward to see you there in this free event. Again, link is on the chat as well as the QR code. Our first event for Black History Month is in Greater Manchester, is the Civic Lounge. It will be attended by, it is supported and very much commissioned by the mayor of Greater Manchester, Andy Berman. So he's going to be in a session as well as representatives, civic leaders from all boroughs of Greater Manchester. This year, we normally do it on the Manchester Cathedral. This year, we're going all the way to Gordon, to the Gorton Monastery. So do join us there, free entry. So you just need to register and join the celebrations on the 25th. For the same event, there is stall opportunities. We're still looking for stalls. So if you have a small business or organization, there's a really important message that you want to share. We are going to be at this event, as I said, very well attended, always a full house. So if you want to showcase what your business does or what your organization does, or even you as an individual, do submit your interest through the link. And we have a very interesting project going on in collaboration with Eva Peel. It's all about Black women's health and gynae health. Apologies, that's not my area of work. I'm not a healthcare professional. I'm just a comms person. But yeah, it's all about gynae health, is about those safe conversations that you can have with our public health specialists here in Cannes. That is compensation for travel support and refreshments. And we're looking for really intimate small groups of 8 to 10 women. So this kind of connects to our conversation about research, how important it is to, be a participant in research. It is things like this, which is like kind of focus groups and conversations and collecting your experience, and is of course completely confidential. The contact is on the screen if you wish to register. I know there's already groups going, and we really look forward to welcoming you. I just want to thank you all for attending. Health Hour is for you. This is why we are here every Saturday morning, and I do look forward to see you next week. Thank you.
Welcome to our Caribbean and African Targeted Health Improvement Programme, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions, spread the word in our community